So we move on to a very important topic, that is micropulse laser in central serous chorioretinopathy. And I think Ajay has done quite a lot of work on micropulse. So I thought it will be nice if he can share his experience.
Mahesh, for this opportunity to be part of this important course of the master class, and I'm talking on central serous retinopathy, when, how, and limitations of the micropulse laser. So there are no financial disclosures, and I think all these points which I wanted to relate have been taken care of. I just stress that we must ask the patient to stop all medications, including the homeopathic medication and health supplements, if we do not know much about them, and they may be causing CSR. So, my protocol for treating any patient with a micropulse laser is that I do not treat an acute CSR. I wait for 6 to 8 weeks. I would definitely ask them to reduce stress, have adequate sleep, stop smoking, use antioxidants, and as others have pointed out earlier, fundus autofluorescence is an important diagnostic tool with OCT, OCTA, and initially, when a patient comes to me, I do an angiogram and an ICG as well. Now, subthreshold micropulse laser is generally not done for acute CSR unless and until patient insists that they cannot wait, and or if there's a chronic CSR, then we treat. So these are the patients which this was a much earlier study a few years back where all patients responded. There were two patients who did not wish to wait, were treated with micropulse laser, and you can see that within about 10 days, patient responded to a single treatment of micropulse, and another patient responded in 2 weeks. Now, what is micropulse? Now, this is a seminal work which was done by Doran et al. Doran, and way back he showed that if we reduce the duration of a laser pulsation to as small a level, we will be localizing the damage caused to the retinal tissue up to the level of 1 microsecond. Will be causing damage to the retinal pigment epithelium. So the burn duration is equivalent to retinal damage. Now here you have a continuous wave laser, and if this laser is split into an on time and an off time, the off time basically indicating relaxation of the tissues, then that becomes a micropulse laser. So a continuous wave laser where you reduce the power to a particular level is not micropulse. It is a micropulse when there is an on time and an off time, so that means there is a duty cycle. For example, if I take a period of 2 milliseconds and the on time is 0.1 milliseconds, the off time is 1.9 milliseconds, it becomes a 5% duty cycle. If this becomes 0.2, it becomes a 10% duty cycle. If it becomes 3.3, it becomes a 15% duty cycle. So when I treat a patient with a continuous wave laser by reducing the power, I will not be producing a damage on detectable on a color photograph, but it will be detectable on a OCT. If there's no damage on the OCT as well as color photograph, that is what happens in micropulse, where there's 100% tissue sparing. And we generally use a yellow micropulse laser, though people have used 532 at 810. The question which people ask is micropulse working? So there was a very good work done in Japan where they did where they did lab studies where they showed on your left is a continuous wave laser, and the mark in the center is the damage caused by the continuous wave laser. So if you look at this particular figure, the damaged retina is in the middle, but the area around it is the area which possibly is the one where people believe something is being produced which causes which reduces the damage, and people believe this is by the heat shock protein 70. So in a micropulse mode, the entire area gets spared, and they showed this. Please look carefully. This is what the damage is, and this is what was shown as production of the heat shock proteins. Now, what power to use? So this was a rabbit study which was done, which showed that as we reduce the amount of power, the damage caused to the retina was reduced. And if you look at it, the probability of retinal damage at 30% exposure was the least. This basically means that if I do a test burn in the micropulse mode and reduce it by 50%, I can have a non-damaging laser to the retina, and that is what is being done now. So earlier we were treating with micropulse with no test burn. Then we were doing test burn in a continuous wave mode. But I have been treating this, and now I think with Jay Chablani et al., all of us all over the world have agreed that if you wish to treat, you must treat with a test burn, which we always give in the nasal part of the retina, usually in the lower infranasal quadrant. And after having got the test burn, I reduce the power depending upon the amount of fluid either to 40 or 50%, and that is how it is done. I'll show you some cases. So this was a patient of chronic CSR, a 63 years old male with an angiogram, and this is how the OCT looked like, and this is post micropulse. Patient did well. This is an interesting dentist who had taken all sorts of treatment, including epineuron. He was on it for last 5 years. He would have recurrence. He will have occasional metamorphopsia. He came to us, and this is his right eye. We had a suspicion of pachychoroid neovasculopathy in his right eye, and his left eye had fluid. So we went ahead and did. So right eye we treated with Eylea. We did not treat the patient with a micropulse in the right eye. In the left eye, we treated the patient with the micropulse. So what happens immediately in the first week? Patient may come back to you with a slight increase in metamorphopsia. So we looked at the OCT. We found that initially the neurosensory detachment of the subretinal fluid would increase, and subsequently it will flatten off. Now, for last 5 years, I have done 3 micropulse treatments for him, and he has remained stable, no epineuron at all. This was an ophthalmology resident, and when he started his residency, you can see that there is a pachychoroid, and he had in his left eye classical CSR. We treated him with micropulse. He has finished his residency now, and he has had 4 treatments of micropulse laser over the period of last 3 years, and he has responded extremely well. Now, what are the limitations? Now, the best micropulse works when the central foveal thickness is between 500 to 600. Earlier, I did not used to treat them if it was more than 450, but we have treated patients above that, and they do work. As I said, I always do a test burn. Usually the test burn is done with a 10% duty cycle is about 1200 to 1300 milliwatts. But please remember, your laser is getting old. So there's nothing like a standard test burn, because the RPE changes in an individual case will be different. So every patient we have to customize the test burn. I always clean the tip of my laser before I do a test burn, because I've had times when actually I was getting a power of 2000 milliwatts in the micropulse mode and yet not getting a test burn. You clean the tip and the laser and it works. In case it does not, which I've had an occasion where it did not work, then I increase the duration from 200 to about 240 milliseconds. Again, do it about 5% duty cycle, and it works again. I avoid the areas that have been lasered or areas of retinal atrophy, as demonstrated by fundus autofluorescence. And as I said earlier, the neurosensory detachment increases in the first 3 to 7 days, and then it comes down. I do not repeat the micropulse. It's been shown in a Korean study that actually you can repeat it on a monthly basis, just like anti-VEGFs, but I do not repeat it for 6 to 8 weeks. And in a chronic CSR, you must rule out a pachychoroid neovasculopathy. So my take-home message is acute CSR observe, stop all steroids, reduce stress, treat other complicating factors like smoking and hypertension. Chronic CSR micropulse laser therapy, especially for the central leak, I go transfoveal. We have treated over more than 20 eyes now, where we have a success in 19 of them, which is, I think, remarkable. Since we don't have PDT available in the country, it can be repeated after 2 to 3 months. It is safe, does not cause damage to the neurosensitive retina. It is definitely cheaper than PDT. There is no dye injection. Octa helps us is detecting the pachychoroid neovasculopathy, which can be treated with Eylea, and subsequently we have treated these patients with a micropulse when we were sure that the PNV has subsided and there's a fluid component which was related to CSR. Thank you. Dr. Giri told me to stop it at 8 minutes. I'm doing
You, Ajay. Unfortunately, I don't think there is time for discussion because we are running out of time, and we will be. Any questions? One question we can take as Vignesh puts a slide.
So normally we do it with a 200 size, 200 milliwatts.
Mm.
I've changed from 5 to 10% duty
Mm.
cycle.
Okay.
Take it to a 40% of my test burn. If it is good, yeah, the spot size is 200 SN. So then, and we cover, I go transfoveal, I cover the entire areas. Supposing there's a leak is subfoveal, then maybe I am a little careful in those cases on going. So you can, I take either 5 by 5 or 7 by 7 because you do a multimodal, this multi-spot, this thing. So I start from the nasal side, come down vertically, go temporally, come down vertically. Then I treat my superior part, treat my inferior part, and then if I'm sure I go transfoveally and I have done it repeatedly, it's not causing any damage.
It's a grid. It's a grid.
It's a grid.
If
Yes.
it's a large area, you can even use 500, but you have to do the test burn with 500. Right.
No, I do a test burn with 200 and I treat with 200.
No,
I
if there's a
don't,
large
I don't
area,
increase the size.
It's a large area, you have to cover the whole area with a grid.
Uh.
Then probably some of the chronic changes.
So the grid can be 5 by 5 or 7 by 7 or 6 by 6. So
Agreed.
I do a 5 by 5 or 7 by 7. So it comes
next
off.
next you
Yes,
okay.
yes.
The other, I mean, even the other one is an axle.
Yeah.